what you say they require most in terms of services, and whether or not the current proposal of the SAF can deliver that?
I think one of the most telling statistics for me is the number of pressure sores that are being recorded by CLCH on a monthly basis, because I think that's quite a good indicator of level of care. And CLCH are completely open about that.
Just remind us, CLCH is...
Sorry, it's Central London Community Health Trust, it's the community NHS trust for the area. They're quite open that that's a problem. And to me, it's quite an indicator of a difficulty in the main very caring staff have enough time to do what they need to do to look after patients competently. And I suppose I think another indicator, really basic things that if you can't get them right, don't tell me you can put more people out into the community, is the flu immunisation rates. We've got really, really bad flu immunisation rates. For staff with the CLCH, they're around 25%, which is the lowest 10 in the country, which is pretty poor. But for concentrating on frail elderly people, flu immunisation is a really good way of protecting somebody, and we've got very, very poor rates for that as well. We've put the stats for that in the paper, and I kind of think there's such basic things that honestly do make a difference to whether somebody feels well and is able to manage at home or has to go to hospital. And I mean, I can give you loads of other things, but I think let's get those really ordinary basic things right first, and then let's talk about doing something a bit more complicated.
Can you just help us by just talking very briefly through your argument that out of hospital services won't reduce the need for acute bed space? I know that's a rather wide question, but...
Well, I think there's quite a... First of all, I just think the argument should be decoupled. I think it's wrong to make expanding out of hours depend on closing acute beds. I think you should be developing the out of hospital and primary care, and if, because it's succeeding, there's less need for hospital beds, that's absolutely fine. I have no personal ties to bricks and mortar, but I think the logic that has to be decoupled. I think if you look at the stats around how we're doing at the moment, and I could go through them, but I think you probably don't want me to, but if you look at the public health outcomes which we've listed, in terms of not just flu immunisation, but all of our immunisations, they're pretty poor. We're not great on a whole number of mortality rates and various illnesses. I think that it's obvious that we've got a long way to go, and I think there's things we need to do to improve that before we can look at taking anything more on. I also think there's a problem that GP practices are getting overloaded in a funny way. We're saying that things are so specialist in the acute service that all the hospital doctors have to be more and more specialists, and yet it's quite illogical, because actually we're expecting the poor GPs to manage more and more and more. The final part around that is, I think that all of the SAHF proposals may get blown out of the water because there are things beyond the control of the local health economy that may affect hospital admissions and health. So wider determinants of health. So for example, we've got a really big problem with air pollution in this borough, which causes a lot of mortality and causes a lot of hospital admissions. We've got a huge problem with child poverty in the north of the borough. We've got a huge problem with some kinds of homelessness, and up in Brent, which is only 3 miles away, the levels of rough sleeper homelessness are massive. I'm just giving examples of things that can completely disrupt any other plans, because all of them lead to a bigger demand for acute services.
Finally, can I just ask you this, just in terms of the implementation of the rest of the SAF programme, what in your view should happen now?
not a speech, but I just thought I'd remember the main points. I think first of all there needs to be an honest debate. So I think that people have to be prepared to listen honestly to the problems, to come to some kind of useful discussion about it. And that partly means not being afraid of the public, actually genuinely engaging with the public. Because to be honest, we're sort of made out to be the enemies of this process, but actually we've all got a genuine interest in getting better primary and community and acute healthcare, and we're all supporters of the NHS. So we could actually have a proper debate about it. I think that there's been too much of a focus within the trusts on stuff that isn't their main job, their clinical job. I think that's backed up by CQC reports. So, you know, being fixated around foundation trust status or getting a bigger market share has become at least as and sometimes more important than basic clinical priorities. I mean, if you go to any of the board meetings, the board papers are piled up, and at least 50% of them are on just bureaucracy that's irrelevant. You know, that's not just a waste of time, it's a waste of resources, and it's silly to put the very, very brilliant clinicians we have, why can't we put them in the operating theatres and in the consulting rooms instead of getting them messing about trying to get 20 more members for the foundation trust bid? And finally, I think that there does need to be adequate resources to fund all of this. And actually, that doesn't seem to me as challenging if you think about how much we're wasting at the moment on competitive tenders and commissioning and blah, 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 blah. I think it's would be entirely possible to have a kind of retreat back into actually practicing healthcare and medicine and ordinary decent nursing, and that would make a difference. And that doesn't mean going back to old-fashioned stuff. I think there are some fantastic out-of-hospital projects here. Like, I'll just give one example, the Coordinate My Care, which is not just about coordinating, it's about planning end-of-life care before you're too ill to make a decision, so that people know what you want to happen, where you want to be. Now, to me, that's a fantastic initiative. If it as a byproduct means that people don't end in hospital, that's fine, but it's actually just a really good use of technology and communication, and it should be supported. So there are really lots of innovative things we could do, but if we could shape it so they're being done for the best clinical reasons, rather than the kind of corporate rationale that's often tied around it, I think we'd be making a better job of things.